cricothyroidotomy and percutaneous tracheostomy. I have some videos. So this is for anesthesiologists. We all know maintaining and emergency control of the airway is very important to us. So that is why this particular topic has been chosen. There are many definitions. I am not going through it. See, surgical airway is in two different scenarios. It is in either in the emergency scenario or the elective. So when it is emergency control of airway, it is cricothyroidotomy, and percutaneous tracheostomy can be done in the elective scenario, especially in the ICU. We all as anesthetists can also do it. So whenever there is a complete ventilation failure, we know that cricothyroidotomy is the only thing which can save us and oxygenate the patient to prevent the hypoxic damage. See, there are many techniques. There is a needle cricothyroidotomy, there is a scalpel cricothyroidotomy, then there is a white bore cannula cricothyroidotomy. We do workshops and also you have to practice for it. See, I will be giving you the video here, but generally if you get your hand on it, it will give you enough practice so that when the situation arises, you can actually do it. So there are many indications, that complete obstruction and all, that patient is unable to, you have done everything, back mask, you put the ET, it's not ventilating. So at that kind of situation, when it is a do or die situation, you can do the cricothyroidotomy. Right? So otherwise death will occur. Scalpel cricothyroidotomy, this is how the landmarks have to be identified. See, this is a very good anatomy where you can see the thyroid cartilage, the Adam's apple, then the rounded cricoid cartilage beneath it, and the soft portion or the dip between the two is your cricothyroid membrane. Right? So I will ask you all to do the laryngeal handshake. Please keep your hand like this, your thumb and the index finger at the hyoid. Palpate the hyoids, right? The hyoid bone, the topmost bone in the airway anatomy. Move it a little side to side, get the feel of it. Keep sliding your fingers downward. Then take your index finger and keep it in the center. So what you palpate in the center now? Thyroid, right? Go below, go beneath. Next, what is the bony part which you palpate is your cricoid. And then you will find your finger actually dipping, falling in between the thyroid and cricoid, right? We have to go by this kind of approach, otherwise we will never be able to locate the cricothyroid membrane in emergency, and preferably do it before. If you are anticipating difficulty, do it before, mark it, and then you can induce your patient. So this is the laryngeal handshake. Then the index finger is palpating the dip between the cricoid and the thyroid. Right? So this is the way the laryngeal handshake has to be done. Try to do at least in your OTs just before inducing the patient. If you can do it on your patient, it will be very beneficial. You will be rewarded for it at least sometimes. The technique is you have to take the scalpel, stab, twist, bougie, and then the tube. Okay? So I will be playing a video. You can just see. So these are the equipment. The umbo bag is required, the scalpel 10 blade is required, the bougie is required. I am doing it here on the boat cadaver. Stab incision is completely perpendicular on the cricothyroid membrane, the lower part of the cricothyroid membrane. You have to make a straight stab incision and keep the shaft towards yourself. Then twist the knife, keep the sharp end in the caudal side. Introduce the bougie. As you can see, you have made a place. Once you put the knife towards yourself, you make place for the bougie to get in. Allow the bougie to get inside the trachea and simply slide over the tube. Which number? 5, 5.5 or 6. Not more than that, because it's a 1 centimeter space and you have to slide the tube inside, right? And then you can inflate the cuff and ventilate with the umbo bag, right? The booby has to be removed. Be very careful that you don't remove the tube along with it. Inflate and with the umbo bag you have to see for the respiration. Okay? So that is how it is simple, but this comes with a lot of practice, right? So next is in the cadaver that I also you can see, because that was a good cadaver. This is in the actual cadaver, taking a stab incision. Identifying cricothyroid membrane is very important. Palpate for the cricothyroid membrane. Point it out. Make a vertical stab incision. Right? And then you have to twist your scalpel. You have to keep the sharp end towards the caudal side, right? And introduce the puji by making space, and that's how you do it. So I have already shown the rest of the procedure, right? So this is the particular steps. This is something which is kind of simple to understand and do, but you really need a little bit of practice. So are you going to search for more cadavers? No, but you can do it simply by keeping your ventilator tubings and all, and do a practice, keep some skill over it. At least let the students practice, and even the faculty, so that you are familiar with the technique whenever the need arises, right? So this is a mnemonic for difficulty. If there is a big hematoma and it's a previous surgery or some radiation distortion is there, you will find it difficult to do this technique also. If you cannot palpate the cricothyroid membrane, it is said it is 4 fingers above the suprasternal notch. So that's how you can locate it, especially when the patient is obese. So the cannula technique, cannula, you have to take a narrow bore cannula. You can take 18 gauge cannula, and the diameter is less than 4 millimeters. So this is what needle cricothyroidotomy, right? So you can just ventilate the patient. Again, you locate the cricothyroid membrane and introduce the needle and the cannula 45 degrees downwards. I'll be just showing. This is what you require for oxygenation, scalpel and the cannula. Right? This is simple needle cricothyroid. If you cannot do the whole procedure, at least if you introduce a needle and key. Sometimes it is even advised that if it is a procedure where you are going to lose control of the oxygenation, you can actually put the needle, the cannula inside, take out the stylet and keep it inside there, so that you can then oxygenate whenever it is required. Right? So this is being done by jet ventilation. I have a video for that, I will show you. So by jet ventilation you can insufflate oxygen within the lungs. So there can be some complications. Remember, barotrauma is one of the dreaded complications when you are giving high pressure jet ventilation. So the only way to avoid it is keep the upper airway patent, keep your neck extended, and make sure that nothing is obstructing the exsufflation of the air coming out from the lungs. So there are other cannulas also. Always practice is much better. There are certain wide bore cannulas like the Cook-Melker emergency kit technique. In this, the procedure remains the same, but you have a stiffer tube which appears to be like an ET tube because it has got a cuff. You can see it here. If you can see it here, that the tube is with a cuff, but this is only 5 mm in diameter. So this is also one way you can do. Now, what's the role of the ultrasound in this is that if you are unable to locate the cricothyroid membrane, you can do a sagittal scan, the ultrasound scan in the midline, and you can see the tracheal rings. The first tracheal, so the bony knobby structures that are visible are the tracheal rings. This is the cricoid, and the thyroid is above that, so that you can locate the cricothyroid membrane. So this is ultrasound can actually help. Now ultrasound also helps you to see the width of the thyroid gland, so that you unnecessarily don't puncture it. Okay, and you can also see the skin to the tracheal cartilage distance. So you can have an assumption of how much needle to extend inside, how much needle to introduce. Right. So this is a photograph which I have taken when we were doing. You can see the shadow of the needle coming in here. Right. So it was kind of like a real time also, that you can actually see the needle entering with the help of the ultrasound. Then there is an open technique, that is when you are just doing like a tracheostomy, but you are doing it through the cricothyroid membrane. You make a vertical incision in the skin, place the retractors bilaterally, and horizontal nick on the cricothyroid membrane. Remember, the neck on the cricothyroid has to be horizontal because the vertical space is very less, not more than 1 mm. Okay? Otherwise, you will injure your vocal cords after that. And straight away, you dilate by the tracheodilator and introduce the tube inside. Okay? I'm not showing the surgery procedure for it. There are other commercial kits available for it. Other techniques are also there, the cricothyroidotomy test. These are different kinds of commercial kits which are available, which makes the procedure of cricothyroidotomy much easier. There are certain guides and it helps us not to go deeper inside, because always remember, when you go through the cricothyroid membrane, you can always touch the posterior tracheal wall. Okay? Now coming to the jet ventilation. So how do you ventilate through a needle cricothyroidotomy? You have to use a jet ventilation. So I'll just come directly to the videos. So you can jet ventilate, we do jet ventilation when we are doing our bronchoscopies, right? So you can make a device like this with the oxygen flush attached to it, with the needle cannula, 2 cc syringe and a connector attached to it, right? So this can be done. As you can see, the cannula, you keep the cannula inside, remove the stellate, attach the 3-way, which is attached to the oxygen flush, and you can press the oxygen flush intermittently, and it is 1 second insufflation and 3 seconds or 4 seconds exsufflation. You can see the air getting in, right? So this is how it can be demonstrated. So now I'll straight away go to the percutaneous tracheostomy. This is one of the techniques which, as anesthetists, we can do bedside. There are many advantages, there are some disadvantages also. But remember, the various techniques are there. That is the Cialia technique, the Griggs technique, and the blue rhino technique. Okay? So I will be showing the Griggs technique, just last video I have. The markings are very important, because otherwise you can go wrong and go to a separate plane. And just finish up the video. There can be use of the ultrasound tool also. In the Griggs technique, remember, you can, now what I am talking about is, so the incision is made at the cricotracheal or between the tracheal 1 and tracheal 2 ring, right? So you can give the local incision out there, and you have to basically dilate with your dilating forceps, right? You dilate the area, go in, so you are not cutting into the tissue, you are not incising the tissue, you are just dilating it. So the local is being given here horizontally, and the needle, by the ultrasound, the location of the tracheal rings are being done, so that the puncture is in the correct side. So it is either between tracheal 1 or tracheal 2 ring, tracheal 2 or 3, but you can at least see that you avoid the thyroid gland, right? So this is, you are dilating just the skin and subcu after making a horizontal neck. Then you have to put in the needle. This is just dilating the skin and subcu with a bigger dilator. This is a bigger dilator. This is the needle which is being introduced inside, always directed caudally. Aspirate for the air. This is usually a 16 gauge cannula needle. Keep the cannula in place, remove the stellate, and pass the guide wire. As you can see, the air is being aspirated, mucus has also come out. The guide wire is gone in. The guide wire is finished. And you finish, the guide wire goes in, and then you dilate it over the guide wire. So you can see that there is a hole in the forceps. Over the guide wire it is being dilated. So once you dilate it, air bubbles should be visible, and then you can put the tracheostomy tube over it. Okay? So that comes to the end of my videos. Thank you for a patient listening.
Thank you so much, Neeta. I request Dr. Prasanth to felicitate Dr.